Hello, everyone. Welcome back to Karan Academy. My name is Karan. I hope you're all doing super well. Today, we're going to be talking about diseases affecting the adrenal gland in our endocrinology series. So I think this is one of those topics which people think they understand, but I don't think they really understand. Um, the primary reason for that being, at least for preclinical years, a lot of the information we learn about these conditions is memory-based. So today we'll be talking a bit about Cushing's disease, Cushing's syndrome, talking about pituitary dysfunction, and then a bit of and then a few more conditions associated with the adrenal gland. So what is Cushing's syndrome? First and foremost, I want you to understand the difference between Cushing's syndrome and Cushing's disease. There are two different things. Both have high levels of corticosteroid hormones in your body. This can be because of a few reasons. Number one, it can be because you're giving someone glucocorticosteroids, and this is the most common reason why you would have a patient who's Cushingnoid. You can also have a patient who has an adenoma in their pituitary gland that is producing high levels of ACTH, which is then going to go to the adrenal glands and produce high levels of cortisol. This would be endogenous cortisol. In this case, and only in this specific case, do we call it Cushing's disease. All these presentations are Cushing's syndrome, but this particular cause associated with an adenoma in the pituitary gland with high levels of ACTH is called Cushing's disease. We'll talk about a few more causes down the track, but what I would like to, briefly touch on are the features of Cushing's syndrome. And these are features of your typical Cushingnoid appearance. So weight gain, hirsutism, menstrual problems, depression, skin bruising as well. Now, the first big brain question for you guys is, well, why do we get hirsutism with Cushing's syndrome? And the reason we get hirsutism, well, hirsutism, as you know, is an androgenic feature, right? It's associated with our sex hormones. But then why do we have hirsutism presenting with high levels of corticosteroids or cortisol-based hormones? Now, when we study about the three main hormones produced by the adrenal gland, namely cortisol, aldosterone, and androgens, we talk about them in isolation and we learn about them in isolation. However, in clinical practice, this is rarely the case. We often have a situation where you have receptors for one hormone responding weakly to other hormones. So we have our receptors for cortisol, we have our receptors for androgens. However, you would still have cortisol weakly acting on androgenic receptors, which is why you get hirsutism, because cortisol is mildly pro-androgenic. The next big brain question is, well, you would know, and because I'm telling you, is that with Cushing's disease specifically, you can also get hyperpigmentation of the skin or a bronze-like appearance. Now, why does this happen? Well, this happens because of the action of ACTH on melanocytes. Now, again, you may be wondering, how does ACTH affect melanocytes? Why is ACTH even involved? When we talk about, again, pituitary hormones, there can be cross-activity, and ACTH binds and responds weakly to melanocytes. This causes proliferation and therefore skin hyperpigmentation. If you have skin hyperpigmentation in someone who's obviously Cushingnoid, that would make you suspect the cause being high levels of ACTH. Now, a very common test that we can use, or not common, but a test we can use to, identify or narrow down our broad list of differentials for Cushing syndrome is something called a dexamethasone suppression test. So let's talk about that. What is a dexamethasone suppression test? Some ground rules. As the name suggests, dexamethasone, we give them dexamethasone. What is the suppression part of it? Well, we try and see whether we can suppress that person's cortisol level. So how does that work? So the dexamethasone suppression test is a two-step process. The first step is a low-dose test. The second step is a high-dose test. The way this works is, let's start with what happens in a normal patient and take it from there. So you start off with giving the person a 1 milligram dose of dexamethasone around 10 p.m. the night before. The next morning, you measure their cortisol levels and see whether dexamethasone was able to suppress cortisol or not. Now, you may be wondering, well, how does dexamethasone suppress cortisol in the first place? Well, dexamethasone, as you know, is a corticosteroid. And the way corticosteroids work are by acting on the pituitary gland. So dexamethasone in your body would act on the pituitary gland, and through its action, which is a negative feedback loop, it would reduce the pituitary's production of ACTH. This low level of ACTH would in turn cause low levels of cortisol. Now, you may be wondering, Karan, you're giving someone a steroid and then you're measuring the steroid. Why don't we have normal level of steroid? Good question. Well, the reason that is the case is because when we measure cortisol, we are specifically measuring the cortisol hormone, which is different to the dexamethasone hormone. Cortisol is produced specifically by your adrenal gland. So if you're able to suppress the cortisol with a low dose, that means that the patient's normal and doesn't have an issue. If you're unable to suppress their level with a low dose, that indicates that they have Cushing syndrome. Next step would be the high dose test. So we do the exact same thing, but in this case, we use a much higher dose. Now, if you're able to suppress the cortisol with a much higher dose, that usually indicates that the issue is at the level of the pituitary. Why? Because, well, it's harder to respond, but it's still responding. It's not some weird, wacky physiological process. However, if it doesn't respond, there are broadly two things this may be. And to differentiate between them, we would then measure the levels of ACTH. If ACTH levels are low, it means that, well, the pituitary is responding. The pituitary is still lowering its levels of ACTH because of the dexamethasone, but then you're still producing so much cortisol by the adrenal gland. Well, what does that mean? It means that the issue is at the level of the adrenal gland. And this is called adrenal Cushing's, typically either due to an adenoma or hyperplasia. However, if you still have high levels of ACTH, that is typically going to be because of ectopic ACTH production. And remember, this ectopic ACTH production would not respond to dexamethasone because it doesn't have that same negative feedback loop that the pituitary has. This is seen most commonly in paraneoplastic syndromes with lung cancers, specifically small cell lung cancers. Now, what are the complications of Cushing's? As you can see, the mnemonic is Cushingoid. So cataracts, ulcers, striae, skin thinning, hypertension. You can read through the list. I'll go through a few important ones. You can have ulcers, both gastric ulcers. This primarily is because of the effect of steroids like prednisolone on the gastric mucosa, but also ulcers elsewhere in your body. This is because of its activity on the skin, typically causing skin atrophy. Why do you get striae? Well, as you know, one of the biggest factors or complications is weight gain, and this weight gain tends to be mostly central and visceral. And with that, if you combine a lot of weight gain with thin skin, that is going to result in the formation of striae. The reason you get hypertension is because cortisol and most steroids are also going to act on your glucose metabolic pathway, and therefore not only raise your glucose level, predisposing you to hyperglycemia and insulin resistance, but also going to be raising your blood pressure. You can then also get infections, and much higher rate of infections, primarily because you are immunosuppressed. Necrosis, specifically of the femoral head, is common because you have osteoporosis plus weight gain. Next, we have glucose elevation, already talked about. Osteoporosis, we've talked about it extensively in our lecture on bone metabolism. Then we also have immunosuppression talked about, and depression and diabetes. Depression is because of the role of steroids on the CNS, but also because you have these whole bunch of complications. And as you can imagine, that can be quite debilitating for an individual. Now, I had a question which I forgot to ask you, which I'll go back to in a second. If you're giving someone exogenous glucocorticosteroids, where will that be on this dexamethasone suppression test level? Like, where does that fit in? Pause this video, take a second, and I hope that you would maybe think that, well, that kind of doesn't really make sense, Karan, because as you mentioned, the dexamethasone suppression test is aimed to identify what is the cause of the person's Cushingoid appearance. If you're already giving someone exogenous glucocorticosteroids, it wouldn't take a genius to put two and two together. And therefore, the dexamethasone suppression test is almost redundant in those cases and therefore should not be done. Sorry for the bit of a trick question. That was a bit mean of me. I'm sorry. But again, going back to important points, good to know. Already talked about all of these. So again, try to understand why. You can also get cataracts because of the inflammatory nature within the layers of the lens, and it also affects the proliferation of the cells, and haphazard proliferation and fibroblast deposition predisposes you to cataracts. Now, what is Addison's disease? Addison's disease, in the way I like to think about it, is the complete opposite of Cushing's, where your adrenal glands have just given up. This can be because of a few things. You can either have widespread hemorrhaging within the adrenal gland, and that's going to obviously cause hypofunction, or you can have a more chronic onset picture due to something like autoimmune adrenalitis. Most cases tend to be quite subclinical, unless the body is under some major stress, and then bam, everything goes really bad, and the patient presents to ED in a very confusing clinical presentation, because none of it usually makes sense unless you're considering Addison's disease as a differential. And you would see this quite commonly in children who may say that they have been feeling off for a few weeks, haven't been eating well, have been losing weight, and then they got sick because something else, a UTI, OT, something happened, and then now they've gone into a bit of a crisis. So because the specific pattern of hormone deficiency can be very random, you should always suspect it in someone who's clinically unwell, but just is not fitting in with anything specific. And we'll talk about the various hormones in a second. And always beware of the Addisonian crisis. This is a big thing we worry about, because this will kill your patient if you don't treat it. So what are the hormones involved? So as you know, your adrenal gland produces aldosterone, cortisol, androgens. You will have, therefore, hypoaldosteronism, hypocortisolism, hypoandrogenism. Kind of makes sense, right? Now, very briefly, you're going to have the opposite of whatever role that hormone does. You know, aldosterone keeps water in and reabsorbs sodium. Therefore, you're going to have hypotension because you can't retain water, and also you're going to start craving salt. And that's going to clinically present with a hyponatremia and a hyperkalemia, because the way aldosterone retains water is by reabsorbing sodium and excreting potassium, which is also why with hyperaldosteronism, you would present with hypokalemia, but not always. With hypocortisolism, we've already gone through what the different features of that would be. And as you can imagine, that can present with both a hypoglycemia and a hyponatremia. And hypoandrogenism, loss of libido, loss of axillary and pubic hair, as well as the development of gynecoid features in males. Now, one thing I'd like to, and as you can imagine, you'd have high levels of ACTH, because your pituitary is going to see your adrenal failing and be like, oh, can we please get more adrenal hormones? And it's going to elevate the levels of ACTH to bring them up, but it's not going to do much. And it's also the reason why you can get hyperpigmentation, exactly because of the same reason we talked about earlier. Now, one thing I want to talk about, we talked about Addison's disease, and I talked about how that can be because the adrenal gland itself has given up. But you can also have secondary and tertiary adrenal insufficiency. So as you know, the adrenal gland is mostly under the control of the pituitary, which is under the control of the hypothalamus. If the adrenal gland has itself failed, that's primary adrenal insufficiency. If the pituitary gland has failed, that's secondary. If the hypothalamus has failed, that's tertiary. One question I would like to ask you, and I hope you just pause this and think about this. And this is a wonderful table taken from Amboss, by the way. I've mentioned that you don't see hypoaldosteronism with secondary adrenal insufficiency. And if you could just pause this video and think about why you don't see that happen. If you remember back to aldosterone physiology, what promotes the release of aldosterone? And if you remember, it's part of the renin-angiotensin-aldosterone system. And aldosterone is stimulated by renin, not ACTH, much like the other hormones. Therefore, with secondary adrenal insufficiency, where you have low levels of ACTH, your aldosterone is not going to be affected because that's affected by renin and not ACTH. And same thing with the hypothalamus. Now, I'd like to very quickly touch base on what I think is a really important topic that's not discussed extensively enough: primary aldosteronism. Now, I'll give you a very brief summary of PA, that's also called Conn's disease. It is the most common cause of secondary hypertension. Earlier, it was considered to be the super rare cause that we don't really look for, but more recent studies have found that 10 to 15% of all hypertensive patients have this. This is caused either by an adrenal adenoma or bilateral hyperplasia. To give you an idea of how well we are looking for this, only 0.2% of GPs ordered an aldosterone to renin ratio, which is the screening test for their hypertensive patients. As you can see, there's a huge gap in what we can be doing. It is associated with way worse cardiovascular, renal, and metabolic outcomes than just essential hypertension. As I mentioned earlier, you can also have hypokalemia with primary aldosteronism, because high levels of aldosterone would cause reabsorption of sodium and excretion of potassium, thus the hypokalemia. However, only 40% of patients actually tend to be hypokalemic. So don't let normokalemia fool you. As I said, you can screen this through a very simple test called the aldosterone to renin ratio, or the ARR. And this can be practically cured and has really, really great outcomes. And this is done either by an adrenalectomy for an adenoma or spironolactone for bilateral idiopathic hyperplasia. I'd also like to make a point. I mentioned spironolactone, and if you've been paying attention, you'll probably be able to answer this. Why does spironolactone cause gynecomastia? Well, it's one of the most common reasons why it is discontinued in the male population. Why does it cause gynecomastia? And again, going back to our principle of the relative effects of different hormones on different receptors, as you know, spironolactone is an aldosterone antagonist, and it would mostly block aldosterone receptors. However, because the three adrenal hormones are so similar, you can also have mild anti-androgenic properties with spironolactone. And therefore, when you start blocking androgenic receptors, that would cause gynecomastia. There have been newer classes of MR antagonists, or mineralocorticoid receptor antagonists, and those have lower levels of gynecomastia, primarily because of the actual blocking pattern, and it's more specific for the MR receptors. And if you know this person, this is Dr. Jun Yang, who's the head of the endocrine hypertension clinic here at Monash Medical Center, and has been doing some excellent work in the field of primary aldosteronism. And that's all we had for adrenal disorders. Thank you so much for tuning in. As always, any questions, feel free to shoot me a message. And as always, please look after yourself and please look after your loved ones.